This is a video presentation on excision of femoral heterotopic ossification, lysis of adhesions, and open posterior capsule release after medial collateral ligament reconstruction. The disclosures for the senior author are listed below. The patient is placed in the supine position on the operating table. Following induction under general anesthesia, a bilateral knee exam is performed to validate clinical findings. This patient has left knee flexion up to 70 degrees compared to 140 degrees of flexion on the right. A well-padded high thigh tourniquet is placed on the surgical limb. Both limbs are draped in a sterile manner, and the surgical leg is placed in a leg holder and the non-surgical leg into an abduction stirrup. An incision is made along the patient's prior incision from the distal aspect of the tibial tubercle to the proximal aspect of the patella. Dissection down to the heterotopic bone is carefully performed, and the dissection is continued posterior-medially to expose the posterior capsule for subsequent capsule release. This patient has significant scarring from her previous surgeries, which complicates the dissection. The MCL graft as well as the heterotopic bone are identified. Using a scalpel, osteotome, and rongeur, the heterotopic bone is carefully removed. The knee is cycled periodically to determine the patient's range of motion and to visualize any lesions that are still blocking motion. Next, a medial portal is created through the open anteromedial incision, and the arthroscope is inserted into the medial compartment just superior to the meniscus. To create the lateral portal, the lateral joint line is palpated, marked with a spinal needle, and incised. Placement of the portals is complicated by the vast amount of scar tissue present in this patient. A combination of shaver, coblation, and Cobb elevator are used for the lysis of adhesions in the anterior compartment, suprapatellar notch, and medial and lateral gutters. During the arthroscopy, the cruciate ligaments and menisci are assessed for injury. In this patient, the previous ACL reconstruction and medial meniscus repair are intact. The cartilage of the knee may also be assessed via arthroscopy. This patient has chondromalacia, as evidenced by fragmentation of the articular surface. Therefore, patellar and trochlear groove chondroplasties are performed. At this point, the patient has 120 degrees of flexion of the left knee. Upon manipulation, the patient's quadricep tendon was found to be tight, so further manipulation was deferred to avoid ligament or tendon damage. After the arthroscopy, an open posterior capsule release is performed through the previously created large anteromedial incision. Capsule release is performed with a Cobb elevator directly against the femur. In this patient, the popliteal artery and vein are less than 5 millimeters away from the posterior capsule. Therefore, an open approach will provide better visualization and reduce the risk of iatrogenic damage to the vasculature. However, an arthroscopic release may be indicated for other patients. After the heterotopic bone has been removed, lysis of adhesions has been performed, and the posterior capsule has been released, a final manipulation of the knee is carried out. The deep tissues are then closed with sutures, and steri strips are loosely applied along with the sterile dressing.